Good morning, everyone. Good evening, and welcome to our International Colorectal web meeting. Today, we have pediatric surgeons joining from Egypt, Spain, Pakistan, Uruguay, Iraq, Mexico, Libya, Kosovo, Sri Lanka, Vietnam, Ecuador, France, Sudan, Russia, and Paraguay. If I didn't mention Thailand. If I didn't mention your country, please type in the chat and I will acknowledge at the end. Today, the first case presentation will be done by Dr. Lara Merino Mateo from Spain. Welcome.
Thank you very much. I'm really grateful to speak today to every one of you. Good morning or good afternoon, depending on where you are. I will share my presentation. So I'm Lara Merino. I'm from Spain. I work in Toledo, and I'm here to tell you a little bit about NL. We got to know Nathaniel NL when he was an 8-month-old infant. He was previously been followed in another hospital and he moved to our region. He was admitted by the pediatricians who didn't know what happened with him, but they knew that he had previously some surgeries and he had some stoma, so they called us to ask about it. The parents report having had 2 previous surgeries and multiple admissions due to gastroenteritis. He had a really low weight and height related to his age. So we start looking through his past medical records. He was a full-term birth with normal birth weight, and he was soon diagnosed of Down syndrome. They describe, and I put everything that I transcribed from his original records in quotation marks. They described that his first bowel movements were in the first 24 hours, but they say that they were scarce. So they performed the first X-ray, abdominal X-ray, on the 2nd day of life, and you can see that there is no distal there. On the 3rd day, because he didn't eliminate much meconium and he got distended, they start doing routine enemas. And again, I don't know, because that's what it's been written, if they were actually enemas or rectal irrigation. But that's the X-ray of the 4th day of life. On the 5th day, allegedly, they perform a contrast enema, and we know that they did because there is some residual contrast on the left iliac region, but we don't have any images of it. So that's what we know. And on the 6th day, he was clinically worse, and on the X-ray, they object the free intra-abdominal air, so they took him to the OR. On the OR, on the surgical report, they describe that there was free intra-abdominal fluid and a generalized intestinal inflammation. They describe a 3-centimeter funnel-shaped zone over the splenic flexure and 2 places with necrotic areas, one in the second, where they did application to close that perforation, and one on the hepatic flexure, where they did a loop colostomy. He also sent some of the some biopsy from that colostomy to study. After all, they did a double bore ileostomy, 15 centimeter proximal to the ileocecal valve. So we understand now what he was having. He was having a loop colostomy on the right side and a double bore ileostomy on the left side. And the histopathology report came back and they described that it was large bowel with some necrotic areas, some transmural necrotic focus and perforation, but they didn't study the calretinine and they didn't say anything about the ganglion cells. They said that there were present of neuronal plexus. And so he was admitted for several days. the first 9 days with parenteral nutrition. He was left MPO for the first 24 hours and then start trophic until he would get full feeding on the second day. He started the bowel movement on after the first day of life, and he had also some mild laryngomalacia. I believe that because they still suspected the Hispanic disease, they did another rectal biopsy. Well, the first rectal biopsy when he was 5 months old, but the histopathologist report that it was an inadequate biopsy. It's written that it was possible that it was a physiologic hypoganglionism because it was too distal, and they say that it was a negative calretinine. So before taking him to the OR, we did in our hospital, we did a contrast enema trying to know a little bit better the anatomy of the bowel. So we see the first from the bottom, the left and transverse column, that is a microcolumn, maybe only from the functionalized by the colostomy. We tried to add a little bit more of contrast to the colostomy to see if we could get any caliber change over the transfer or the left column. And we study also from the ileostomy to get a little bit of a hint about the duplication on the cecum to know if there was some structure after the previous surgery, but the radiologist said that it wasn't. After the study, he was admitted for a few days to the ICU with a clinical sepsis, with some signs of colitis in the X-ray. So to summarize, we have an infant, but we don't really know if he has a Hispanic disease. So maybe we should do a full thickness open biopsy again to make sure that it's a Hispanic disease. If they really did rectal irrigations and they weren't enough, and he got perforations so early in his life, so we suspect that it's a long segment Hispanic disease. So we do a mapping, and if we do, should we do a laparoscopic and get more points, or should we only do from the stomas? With all him having this failure to thrive, and what we now think that they were multiple Hispanic-associated enterocolitis, so we try to gain him some weight before doing anything more, and trying to getting him to gain more weight. So we close that ileostomy and do an end colostomy to try to get more absorption of the nutrients. Or should we leave the ileostomy expecting that it's a long segment and it will be better or easier after that to do the pull through? And last and a little least important, but again, looking him in all the ways, he had a left non-palpable testicle, and thinking that maybe we do laparoscopic mapping, should we try to do the first stage Fuller-Stephen procedure at the same time? That's my questions.
Thank you very much, Dr. Lara. So if there are any questions, please type in the chat. I'm going to make a brief comment, and then I'll let Dr. De La Torre and Dr. Peña comment also. I think we have to remember patients with Down syndrome, they are at very high risk for severe constipation. So we always have to keep that in mind, because they have constipation. Many of them also have hypothyroidism. And what called my attention in that case, or if that case has presented to me now, I would start almost in the same order that you put on this slide. First, we have to clarify for good if he has Hirschsprung or not. So I would take the baby to the operating room, use the Lone Star, make a very good full thickness rectal biopsy, send to a pathology with expertise so you know for sure if it's Hirschsprung or not. The baby now is safe, the baby is diverted, so there is no reason to rush. So first, I would do a full thickness rectal biopsy. Then I will know, is it Hirschsprung? Yes. If it is Hirschsprung, then I'm gonna map what's the Hirschsprung, so I could map and do the Fowler-Stephens, for example, and then keep the baby with the ileostomy. In that case, while I'm waiting for the biopsies to come back, I would measure the urinary sodium, and if it's low, less than 20, I would start oral sodium supplementation, because that's the most common cause in those patients of not growing and also enterocolitis. If it is a long segment, it explains why he doesn't respond very well to rectal irrigation. But if it is a total colonic aganglionosis, we don't close the ileostomy until the patient accepts rectal irrigation and it's toilet trained for urine. In patients with Down syndrome, this may be way beyond 3 years of age. We're talking about 6 years of age in the best ones in terms of development. Do you have any comments? Dr. De La Torre, comments? Where is Dr. De La Torre?
Morning. Hello, Lara.
Hi.
Yes, I agree with Andrea. Are you able to take another rectal biopsy? I think if you can do a new rectal biopsy, it's going to help a lot. So you have the opportunity to make the diagnosis or rule out the diagnosis of Hirschsprung. Remember, it doesn't matter the length of the ganglionosis. Always the diagnosis of Hirschsprung always is in the rectum. So if you go to the OR and take a full thickness, good full thickness rectal biopsy in this special case, then everything is going to be very clear. That's my first recommendation. Also, you can ask for a second opinion in the initial biopsy. But I think if I have this patient here in Denver, I take the patient to the OR and I take another biopsy from the rectum, and that's it. That is going to clarify everything. I don't suggest to do a mapping like a laparoscopic or open, whatever, because it's going to have another abdominal surgery. This patient already has many surgeries, and you don't have a clear diagnosis. And the diagnosis of Hirschsprung, you can establish with a good rectal biopsy. And then we can see the next step. That's my comment, Lara. Nice to see you.
Thank you.
My colleagues already mentioned about the diagnosis of Hirschsprung disease. I will add something. I will give the baby the benefit of the doubt. In other words, don't trust the histologic diagnosis that has been made so far. We don't want to offend the pathologists, but we simply want to give the baby the benefit of the doubt. I will take those biopsies that already mentioned Dr. De La Torre and Andrea Bishop, and I will send them to different pathologists all over the world, particularly when some pathologists made the diagnosis of hypoganglionosis. When we hear something like that, we become very skeptical, because personally, I don't know what is that, and nobody gave a good definition of that condition, hypoganglionosis. So I will send the biopsies to Colorado and to also to, what's the name of this?
Puebla.
Well,
Puebla.
well, no, what's the pathologist?
In
Kapoor, Dr. Kapoor, and our pathologist in Colorado is excellent. So, and confront the opinions of different pathologists in order to answer the first question: is that, are we dealing with Hirschsprung, yes or not? And depending on that, then we can make a management plan.
So there are a few questions. I think one is related with hypoganglionosis. So the question was, how many ganglion cells do you need to make the diagnosis of Hirschsprung? Remember, Hirschsprung diagnosis is 0 ganglion cells. It's no ganglion cells and creatinine negative. And the other question was, instead, when you take the patient to do the rectal biopsy, can you also biopsy the ostomy sites? I think at least Dr. De La Torre, Dr. Payne, and myself, we would just do the rectal biopsy. We have to clarify the diagnosis. We don't want to create more morbidity. So at this point, I would just focus on doing a good full thickness rectal biopsy so we have the diagnosis. Thank you so much, Dr. Lara. I'm gonna now invite the next presenter, that it's Dr. Ismael Ehsan El Halabi from Egypt. Welcome.
Thank you so much. Now I'm going to share my screen. Okay, so you can see my screen now.
Perfect.
Perfect. Okay. Thank you. So thank you, Dr. Pina, Dr. De La Torre, and Dr. Bishop for giving me the opportunity and for the Hinder project. It's always great to join you in these cases. What we are going to just going to minimize this. Okay, so what we are going to present today is a case of a long segment Hirschsprung disease. And there's always this dilemma when you receive a patient with long segment Hirschsprung disease who already has a colostomy. So I'm going to elaborate on that shortly. So our patient is a 1-year-old male child. He was born at full term by C-section. There's no history of chronic maternal illness or significant obstetric history. According to his notes, because he was born and operated primarily in another country, he developed progressive abdominal distension with refusal of feedings during the first week of life. And there he underwent an abdominal exploration. According to the notes on exploration, it was found that he had a transition zone at the transverse colon. So back there, they did a divided defunctioning transverse colostomy. And this is the picture of the abdomen of the child. So basically, the stoma on the right side of the abdomen, that's the proximal one, and the one on the left side, that's the distal one. Now, also, after we have reviewed the biopsies that were taken, and we had to make sure that these biopsies were taken in a good fashion, found that the biopsies taken from the rectum, sigmoid colon, descending colon, and the proximal and distal stomas, they were all taken, and all of them confirmed the diagnosis of Hirschsprung disease. And the proximal stoma, it showed well ganglionated stoma. So our question is, what would you do next for this patient? Would you do a contrast study from the stoma or a contrast enema? Or you can go for the surgery and take the stoma down and do a stoma pull-through, or you can go for surgery, do a pancolectomy, remove all the colon and do an ileoanal anastomosis, or you are not sure. Okay, so we got the results. So 63% said that we can go for the surgery and do a stoma takedown, and 33% said that the patient need a contrast study. 4% said that we can do a pancolectomy. That's one of the people who answered. So we believe that maybe we are not going to benefit so much from the contrast because we already know that the whole distal colon is aganglionic. So we decided to go for surgery and to do a stoma takedown. And when we look here, that's the view that we got after we did the exploration through the wound and we dismantled both stomas. So on the left side of the picture, that's the proximal stoma leading to the ascending colon, and then the cecum is down there. You can see the appendix. We are going to elaborate in that more in the next slides as well. And on the left side of the abdomen, that's the distal stoma leading to the whole bowel, which is going distally. Then after we did a little bit of mobilization, this is a video that I'm going to show just to show a little bit more of the anatomy. Again, that's the left side stoma, and that's the right side stoma, the proximal one, which is being held by the bowel clamp. It leads to the cecum. The cecum is being pinched here. You can see the appendix as well. And to bring down the stoma, there are some options. This is one option, to do this clockwise rotation and then cross the bowel going down. Or you can do this anti-clockwise rotation, where basically you are going to place the cecum on the right side, and then the stoma can be pulled through in this way. So as you can see, there are two options, and I can ask the audience what they think we should be doing this. Should we sacrifice this whole segment of the cecum and the semicolon and do a straightforward anal anastomosis, or we can do mobilization of the right side of the colon and do a clockwise rotation as we have elaborated, or would we do a right side colonic mobilization with an anti-clockwise rotation, or you're not sure? Okay, so we got the results. 30% answered and 63%. 30 people answered and 63% said that we can do an anti-clockwise rotation, and 33% said we can do a clockwise rotation. I'm going to show a little bit more about this through a figure. So basically, this is the picture that you get when you do the clockwise or the anti-clockwise rotation. So on the upper picture, that's when you rotate the bowel anti-clockwise. So basically, the cecum will lie on the right side and goes down in this fashion. When you do the clockwise rotation, we believe that there is a possibility that this part of the terminal ileum or this part of the stoma that's going to be pulled is going to compress this part of the terminal ileum. So we opted to do colonic mobilization with an anti-clockwise rotation, and that's the picture that we did after some mobilization. So again, here's the proximal stoma leading to the ascending colon, the cecum, and the appendix. And we did a lateral mobilization of the whole colon. And we're going to show again, if we do this, we believe that we are going to compress the bowel here, the terminal ileum. When we can do the other way around, we can do the anti-clockwise rotation, as you're going to see in the picture, after mobilization. But then again, this would need to mobilize the whole level of the whole colon and then the whole terminal ileum and the small bowel in order to place them on the right side of the patient. Okay. Also, you can appreciate that the patient has been suffering from recurrent attacks of enterocolitis, and you can appreciate the severe lymphadenopathy that's present in the mesentery. Okay, so we did this right-sided colonic mobilization. We fanned the whole bowel. We placed the whole small bowel to the right side. We made sure that there is no kink, absolutely no twist. And this is the whole picture that you are going to get after you do this mobilization up to the level of the duodenum. So a close look to this picture, you can appreciate here the stomach, and that's on the left side of the patient, going down to the duodenum, which has been straightened, and then the pancreas is there at the bed of the stomach. Here is the ileocolic artery, the ileocolic branch of the superior mesenteric artery. And that's actually, if you look closely, that's another branch. This whole marginal branch is the branch that feeds this whole segment of the bowel that you're going to pull through. This is the picture again of how things look like. And then we decided to start on the pull-through procedure. So what we do is we take sutures between the distal end, distal end of the stoma, and the proximal stoma, which is going to be pulled through. And then if you look closely, that's the segment of the bowel. This one pointed with the green arrow, that's the segment of the bowel that's going, the distal bowel, that's going straight down to the rectum and the anus. After that, we move on to the perineal portion of the procedure. We place Lone Star retractor, and then we advance the pins step by step till we go above the dentate line. Then we place a Kelly clamp, a large Kelly clamp, inside through this rectum, and then we take a grasp of part of the bowel, the distal bowel. Here in the video is going to be more obvious, and then we start to do the Swenson prolapse. So we take this bowel out, and then that's basically we have prolapsed the whole bowel, the whole distal bowel. Then we are going to mark over here, that's the distance from the dentate line, and that's the distance that we are going to cut exactly along these dots that we are going to cut. And that's the picture that you get. Then we do completing the prolapse through this window. And step by step, we start to pull through the colon that has been mobilized. And you can see here, that's the silk sutures that we have taken between the distal one and the part of the bowel that's going to be anastomosis. So afterwards, we did a coloanal anastomosis, and the patient had a smooth post-operative recovery. We reinitiated feedings 2 days post-operatively. we just have some few take-home messages that need to be really clear, which is when you are going to do a pull-through for a right side colon, it can be really tricky because there are so many details involved in such procedure, and you have to really make sure that you are not doing any twist of the colon, you are not kinking any blood supply, not doing any potential bowel compression because we have previously seen such complications. That's why this pulling through the stoma on the right side, I believe it's not a really straightforward procedure, and you have to be really cautious about it. Thank you so much.
Thank you very much. I think we all enjoyed seeing the videos. What a good demonstration on how to bring the right colon down. The only comment that I would make, and I think we have discussed this before, is that in the traditional teaching, transverse laparotomies were the best approach, but we truly believe that for colorectal procedures, the midline laparotomy offers the best exposure, especially when you're gonna do pelvic dissection. We like to extend our incision all the way to the pubic bone. We like to really see the bladder, move the bladder forward so we can see the trajectory of that pull-through bowel. So I'm impressed that you were able to do the surgery through an upper transverse incision, but I think it would be much easier if you did it through a midline laparotomy. Dr. Peña, Dr. De La Torre, comments? Comments?
No.
Dr. De La Torre, comments? Oops, Dr.
Dame un segundo.
Okay, 1 second, he said. So we
Okay.
have to.
Ismael, congratulations.
Thank you.
I always said that there are 3 types of Hirschsprung. One is the total colonic. So the problem is very easy to resolve. You do a ileostomy, and then you wait 3-4 years, and then you can do a pull-through. The other type is the patient that is the most common, is the rectosigmoid. You can do transanal approach, you can do transanal and laparoscopic, or your laparoscopic, whatever you do. It's very easy to approach. The most difficult and the most common complicated cases are these ones, when you need to mobilize the right colon. I have seen many catastrophes, patients that they lost the entire bowel because they have the blood supply compromised the small bowel, and they lost all the small bowel, necrosis, stenosis, and many other issues. So the most challenging type of pull-through is when we want to mobilize the right colon and do the pull-through using the splenic flexure or even a more proximal segment. Thank you very much for this very interesting case, and that's my comment.
Thank you.
Thank you very much. So we are now gonna move. Oh, there was one question. If would be good to have an ileostomy, expecting that this patient will have a lot of diarrhea with this short colon. I think it's always an option to have a protective stoma. And yes, this patient will have to be watched very close because with that short colon, they will struggle with some diaper rash. So thank you very much. We're gonna move now to the 3rd case that will be presented by Dr. Julio Cesar Moreno, also from Spain. Welcome.
Thank you. We are going to share our screen.
Perfect.
Yes, it's correct?
Yep, perfect. Thank you.
Okay. Good morning, everyone. We appreciate the opportunity to present this case. My name is Julio Moreno. I'm pediatric surgery resident at the University Hospital of Navarra in Spain, under the supervision of Dr. Elena Calleja, one of my mentors. Today, we would like to share with you an interesting case of a neonate with abdominal distension. Our patient was born at 40 weeks with an appropriate weight and no anomalies in the prenatal care. He had been born without problems in another hospital, from where he was referred at the 4 weeks for suspected intestinal occlusion. After delivery, he began oral feeding with vomiting, abdominal distension without expulsion of gas or meconiuresis. On examination, the external genitalia and anus were normal, and on rectal palpation, it was not possible to pass the little finger, so Hagar dilators were tried, reaching only up to number 3. On arrival at our hospital, an abdominal X-ray was performed, identifying a significant distension on the left colon and a sacral anomaly, as you can see in the X-ray. Therefore, rectal stimulation and enemas were started, which were partially effective. So, with this information, what is your main possible diagnosis? Hirschsprung disease, meconial plaque, Currarino syndrome, or anorectal malformation. Okay, anorectal malformation, 43% of the participants, then Currarino syndrome and Hirschsprung disease. Interesting. So we are going moving on. Yes. To continue with the case, 3 days of life, an opaque enema was performed without being able to visualize the rectum anal area, and an abrupt termination of the rectum in the form of a beak, as you can see here, was identified, as well as a dilatation of the sigma, all of them suggestive of rectum anal stenosis. At this time, oral tolerance was good and nursing was continued or established since the patient did not have spontaneous bowel movements. Subsequently, an MRI was performed identifying a right hemisacral agenesis with a tethered core and anterior myelomeningocele, as you can see in the picture. All of this compatible with the Currarino syndrome. Posteriorly, at 12 days of life, a calibration, stimulation, and dilatation was performed in the OR, identifying an anal stenosis of 2 centimeters in length with a slight muscular weakness in the anterior anal region, being able to pass only up to the Hagar dilator number 4. So a pneumatic dilatation up to 8 millimeters was performed. And as the only incidence in the postoperative period, the baby presented a mild perianal cellulitis that was treated with antibiotics. With all of this information, the diagnosis of Currarino syndrome was established and confirmed, and rectal irrigation and anal dilatations were continued, and with good evolution and discharge at 1 month of life by social and neonatal issues, but not by gastrointestinal problems. And at 40 days of life, a new exploration was performed in the OR, being able to pass up to the Hagar dilator number 8, and an enema was performed in the OR, showing a distal area in the shape of a funnel, as you can see here, and an anal rectal stenosis area of 15 millimeters. With these findings, we decide to keep the nursing and anal dilatations at home. And at the last outpatient visit at 2 months of age, the mother referred significant pain with the dilatations and occasional spontaneous bowel movements, depending on the nursing to evacuate properly. In addition, an abdominal X-ray showed persistent dilatation of the left colon, as you can see here. In this context, which options would you consider more correct? Hegar dilatations, pneumatic and Hegar dilatations, colostomy and then pull through or posterior sagittal anorectoplasty, colostomy plus posterior sagittal anorectoplasty or pull through. Interesting, most of the participants think colostomy and then posterior sagittal anorectoplasty or pull through. In this moment, this is our plan, but we are going to talk about that. So, as I have talked, our plan in this moment is colostomy first, and then posterior sagittal anorectoplasty or pull through. About myelomeningocele repair, depending on neurosurgeon criteria. So we would like to know your opinions regarding this case. What do you think of the plan we have proposed? Do you think there are other alternatives or better approaches maybe? What is your experience regarding the timing of myelomeningocele repair? So here is the case and our concerns. Thank you very much for your attention.
Thank you very much. This is a very interesting case. So the first thing that I would like to remember, everyone, dilations should not be used in real stricture, in real stenosis. So those patients with Currarino triad, they do not respond to dilations. So if I had this patient in front of me and I could not pass my finger, this patient for me needs a colostomy, and then I'm gonna investigate the patient. Now, there are some patients with Currarino triad that they are stooling and you diagnose later. Those, depending on your experience, may not need a colostomy. But in a case with a severe anorectal stenosis with very important sigmoid dilation, I think the safest option is to do a stoma. There has been cases in which the dilation causes perforation, so it is very dangerous. So I would say it's contraindicated to try to dilate, and they do not respond. Now, in this case, whenever we have a Currarino triad, there are many possibilities for the presacral mass. The most common one, it's a benign teratoma. But it can also be an anterior meningocele, like in your case. When there is an anterior meningocele, again, my recommendation would be do the colostomy, let neurosurgery take care of the mass, at least disconnect, because the area of the stenosis will be exactly where the mass is. And you don't want to inadvertently open that when it's still connected to the dura. So my recommendation would be colostomy first, let neurosurgery deal with the anterior meningocele, and then you can remove the distal portion and make a pull through for this patient. Comments?
Yes. Dr. Currarino was a radiologist that worked in Texas, and he described what is called the Currarino triad. And the triad consists in hemisacrum, that's what he described, hemisacrum and anorectal malformation.
And presacral mass.
And presacral mass. So, but I don't like it very much to use that term because sometimes the patient doesn't have a hemisacrum. Mm-hmm. Sometimes actually they has a bifid sacrum. You know, they could be a mass in one side or on the other side. Could be in the middle with a bifid sacrum. So I rather try to be without taking the credit to Dr. Currarino, but I like to describe the malformation. This is a bifid sacrum or a hemisacrum on the left side with a giant mass. But right from the moment that the doctor showed us the X-ray of the sacrum at birth, we knew that the patient had a presacral mass. And that patient, from my point of view, would need a colostomy. dilatations are absolutely, that simply don't work, and they are dangerous also. They may perforate the rectum. And then there are two ways to approach the anterior meningocele. One, Dr. Bishop already mentioned, is to let the neurosurgeons approach the patient from behind and close the anterior meningocele. And then when you go to repair the presacral mass, you will not have a risk of opening the meningocele. The other approach will go right after the colostomy, posterior sagittally, remove the mass, and you will find the meningocele right there. Try not to open it, and then the neurosurgeon can try to close that at the same time, and then you take care of the concerning the stenosis. You have to resect the stenosis. You have to take normal rectum and pull it down and anastomose it to the anal canal, or to a non-stricture area, but it needs or sometimes you have to do a full pull through of that, but that's the only way to do it. Something, a real risk is that you enter to the upper end room posterior sagittal to remove the mass, and then inadvertently, accidentally, you open the meningocele, and then you close it. You close it in the way you know, but chances are that will not close. And then you have a patient with a cerebrospinal fluid fistula, and that's very, very bad. As that, the MRI that you shows the meningocele, but didn't show very well the presacral mass. I don't know if you can show it again. There,
Yes.
there is a meningocele, and then the mass. But at that in that image, I would put a tube in the rectum to see exactly the role, the presence of the mass and the meningocele. As you can see in the image, when you remove the mass, that most likely is a dermoid or a teratoma, you have to be very careful in not opening the meningocele. I remember having done in a 50-year-old man a big meningocele in a presacral mass that was never resected, and I was able to resect the mass and preserve the meningocele, but you have to be a very delicate surgeon. And by the way, the prognosis for bowel control is not good in those patients. He will always suffer from constipation. He will always have to be followed up by you. Will need trial of laxatives that may exacerbate the incontinence, and if it doesn't work, then you need bowel management with enemas.
And also neurogenic bladder. So it's very important that this patient is followed by you and urology, because most likely we'll need enemas and intermittent catheterization for the bladder. Dr. De La Torre, any comments?
No, I agree. Thank you.
Perfect. So we're gonna move to the last case that I'm actually the one presenting. So let me find it here. Oops, 1 second. Okay, give me 1 minute because I thought I had my case here, but I don't. Just 1 minute. Do you have my case, Ray?
I can pull it up. Give me like 1 minute.
Okay, I thought I had it here, but I forgot. Yep, I don't have it. I'll let you pull for me because otherwise I would have to open my email. So let me see if there is any questions as we are. No questions in the chat. Okay.
You may need to tell me when to change the slides.
Okay, we're not in, we are seeing the several slides, not the
Oh.
one single presentation.
Okay. Let me go back again. Hold on.
Okay. Let me see if there are any questions here. Continence, we talk. Patient with CT, we need contrast to check if one type of.
That better?
It's better. Okay, so now we're going to present the fourth case, and since we were on a Hirschsprung chapter, I decided to present a case of Hirschsprung 2. Next. Let me just move this. So this is a 1-year-old male patient that was born and operated due to Hirschsprung disease in another institution, complicated by an anastomotic leak that required a diversion, ileostomy, and later had an ileostomy closure. The patient had the operations during the first month of life, and he was still doing anal dilation and unable to win dilations. So parents kept going back to the surgeon and say, are we ever gonna stop dilations? And the answer was just continue doing. So the baby was dependent on anal dilations in order to stool. So that's why the mom thought I should look for a second opinion, and then the patient came to our center. Next. So those were the newborn images. So you can see that the patient was the classic rectal sigmoid Hirschsprung disease. Next. And then, as I mentioned, the patient had a laparoscopic assisted pull-through, suffered from a leak, and ileostomy was opened. And this was a contrast enema that was done prior to the ileostomy closure. So if you look at the most distal portion at the neorectum, you can see just a thin line near the Foley down below. You can just see a thin line. Next. So with this history, what would be your approach? Rectal examination under anesthesia, full thickness rectal biopsy, contrast enema, continue dilations indefinitely, inject Botox or inject steroids, more than one option, or I don't know.
I can't put up the poll and share at the same time. So if you put your answers in
Okay.
the chat, that'd be great. Sorry about that.
That's okay. So just type in the chat, what would be your option? Let me see if I have access. I don't have access to the chat now. Oops, I do have. So rectal examination under anesthesia, I don't know. More than one option. More than one option. 1 and 2, rectal examination under anesthesia and full thickness biopsy. Very good. Next. So our plan was to do a rectal examination under anesthesia with biopsy and repeat the contrast enema. So when we took the patient to the operating room, we found a severe stricture that did not pass my little finger, and there was no way to do the biopsy because we didn't have access to the pull-through bowel, meaning the stricture was so severe at the level of the anastomosis that there was no way to retract to have access to the pull-through bowel, so we could not do a biopsy. But at this moment, it was clear that the patient needed a reoperation. And we also did the contrast enema. So this is the scout image, and you already can see that there is the sigmoid, the descending colon, and a little bit of the sigmoid dilation, and you don't see anything distal. Next. And when the contrast was injected, you can see that there's very fibrotic distal area. Next. And here you can see just a line where the neorectum is. Next. So we took the patient to the operating room. We did full bowel preparation because this patient does not have a stoma. And there you can see what a real stricture look like. It's this very white fibrotic tissue. It's not a healthy tissue. So this is not something that can be dilated. This is a real stricture. So we placed multiple 5-0 silks. We dissected, and despite full dissection, this rectum did not come. It's what we call frozen. because of the fibrosis. So we knew we needed to go to the abdomen because we have to bring a healthy bowel down to make the anastomosis. So at this point, when we were completely free and we still could not gain any length, we decided we put a knot in the silk, push it inside, and we go to the abdomen. Next. So when we enter in the abdomen, we were able to complete the dissection. You can see the sutures on that side of the screen with the silk. And what I wanted to show here is just how important it is when you're doing a pull-through to study the blood supply. Next picture. So we do with transillumination. So we put the lights on the other side of the bowel, and then you can really see the arcades of the bowel. So in order for that piece of bowel to reach the perineum, we have to palpate the pubic bone. And if it is 2 centimeters or 4 centimeters or 2 fingers below the inferior rami of the pubic bone, we know that when we bring it down, it will reach. So in this case, if we needed, we would confirm. You can see that the blood supply goes like that. We would confirm that we have one going down. Then we could ligate the first one. It was not necessary. We just ligated the avascular band. We preserved that vessel, and the good bowel reached the perineum without tension. So here you can see the incision that I mentioned. It's an infraumbilical midline incision. We go all the way until the pubis. We move the bladder forward and we have full access to the pelvis. So we can see that bowel going down. Next. And here's the anastomosis. In reoperations, the main message, you can go to the next slide. In reoperations, we never can guarantee bowel control. In the beginning of the operation, we could not even identify anal canal, pectinate zone. It was just fibrosis. And it's very important to discuss with parents prior to the reoperation, so the parents can adjust their expectations. And also when you do a reoperation, we always enter with consent for transanal, laparotomy, protective stoma, because you never know what you're gonna find. In this case, we felt very good. We were very happy, and we did not need to open a protective stoma, but we kept the patient 7 days NPO on TPN. But we had consent to open a stoma if needed. So I think that's my main message, is that in reoperations, never assume that it's gonna be a minor thing. Oh, it's just a stricture. You never know. This case, we were lucky. Dr. De La Torre was with me. We did together. And it ended up being relatively easy after the dissection of the anus that was very, very fibrotic. But we cannot guarantee bowel control. Comments?
And this patient was a history of leakage, right?
Yes.
So the patient had a problem with leakage, means already that the patient has something very serious. Leaking anastomosis and pull-through occur because of 2 reasons mainly. Either tension in the anastomosis or ischemia in the distal part of the bowel, or both together, see? So when you anastomose a healthy piece of bowel and without tension, there should never be a leakage and should never be a stricture. Now, when you have history of leakage and stenosis, you expect that you will find something much worse than stenosis. You will find a lot of fibrosis all around, like we call a frozen pelvis. And don't try to dilate that, because that will you will never be able to dilate that, and the patient will suffer a lot, and you will make the fibrosis worse. It's better to accept that the complication is serious and go for a redo.
Okay, we can close the presentation. Let's see if there are any questions. Dr. De La Torre, do you want to comment? You did this case with me. Or Dr. De La Torre? Do you want to comment, Dr. De La Torre?
No, just in this case, I remember that it was very difficult, the dissection, and yeah, the risk. Already Alberto did a comment about the risk of fecal incontinence. This is the Hirschsprung type 1. This patient was able to be treated by a transanal approach. This patient did not require any abdominal approach, and I think the outcome will be different. Unfortunately, many surgeons try to do always laparoscopic approach because it's very fancy, but this patient had a very short segment. I don't want to say short as ultra short, but it was reachable by a transanal approach. Unfortunately, something happened during the pull-through, and the catastrophe was the outcome. But this is the type 1. Thank you, Andrea.
Thank you, everybody. So I think we're gonna end our meeting. And again, I just want to thank you all the presenters for very interesting cases, and the pediatric surgeons that join us from Egypt, Spain, Pakistan, Uruguay, Iraq, Mexico, Libya, Kosovo, Sri Lanka, Vietnam, Ecuador, France, Sudan, Russia, Paraguay, Thailand, Saudi Arabia, Afghanistan, Indonesia, and Peru. I think I mentioned everyone, so we hope to see you next month. Please send your cases. We can all learn from each other, and we'll see you on March 14th. And Mexico, I didn't I mentioned Mexico. Montenegro, thank you. South Africa, Julia. Oh, many more. South Africa, Nigeria, Turkey, Philippines. Sorry, I miss many countries today. Austria, Philippines, Germany, Egypt, I mentioned. Hi, Basma. Tunisia. Wow, I mentioned I missed many countries. I'm sorry. Bangladesh, Pakistan, I mentioned. Perfect. Thank you, everyone. Bye-bye.